Welcome to this video on PET-CT in oncology. This video will be divided into two parts. The first part will talk mostly about the protocols, and the second part we will talk mostly about the images. Here are the objectives for this lecture. This is an example of normal biodistribution. Notice in this picture, this was an eyes to thighs study. The top of the brain is cut out of the image and the patient's arms are above their head. Normal biodistribution, the FDG is transported through the cell membrane through facilitative glucose transporter proteins. It's then phosphorylated into the cell and is trapped. The tumor cells have increased number of transporters. They take up more of the glucose and then it gets trapped in the cell. At 45 minutes, the FDG accumulation plateaus in tumors. So technically you could scan them anytime after that. That's the bare minimum. And then at 2 hours, the highest activity levels are seen in the brain and the heart, if they're not fasting, and in the urinary system. And FDG is primarily excreted through the urine, so it's normal to see the bladder being very hot, ureters, and also the kidneys. Normal biodistribution will appear in the brain, liver, kidneys, bladder, salivary glands, thyroid, heart and vascular structures, spleen, esophageal ampulla, stomach, bowel and the colon, the endometrium during menses, bone marrow, muscles, and testicles. You'll also see the thymus in children. Because pretty much every cell in your body uses glucose, the normal biodistribution is varied. So this is another example of normal biodistribution. This is a coronal view at several different slices through the same patient, so you can see how the anatomy changes as you progress, through the patient. This is showing the first 16 slices of the coronal view. There are a lot of normal variations of FDG localization. This will go anywhere where there are sites of inflammation or infection. And it has a lot to do with the patient's metabolism. So sites of infection, recent biopsy sites, muscles in patients who exercise frequently, and small and large bowel. If you're looking for GI activity, then it might be a good idea to do a bowel prep, just so that GI activity isn't there. So the first image here shows normal variation in a gastrostomy tube. This is in place in the abdomen and is seen on the CT scan, which is in B. You see it showing up dark with contrast. The PET scan demonstrates elevated FDG uptake along the insertion route and the perimeter consistent with inflammation. So A is the CT, B is the PET only, and then C is the fused image. So here's the gas uptake in the gastro tube right there. And then on the fused images, you see it right here where my mouse is pointing to. On the CT, you actually see the hardware of it. So the second image here is a patient with breast cancer that illustrated intense activity accumulating in the left ear because of a chronic ear infection. And this was a mixed infection that included multi-resistant staph and aspergillus. Sorry. So A is the CT scan, B is the PET, and C is the fused. You don't see a whole lot there in the CT. On the PET scan, you see it right here in the left ear. Remember, these images are reversed, so right and left are backwards. You're actually looking at the patient from their feet up. And so this is the left ear over here where there's some FDG uptake. This is normal myocardial uptake variation in patients with normal fasting glucose levels. Um, so A is patchy, or A is intense, B is patchy, and then C is absent activity. These are other different variations. A is showing a healing surgical wound, which you see right here towards where the belly button would be, where my mouse is pointing. B is intense coughing. What you're seeing there is not really the ribs. What you're seeing there is the muscle between the ribs, and then some of the abdominal muscle and muscle in the neck from intense coughing. C is muscles from exercise, which is why we have our patients rest during the uptake portion. You see that they have a lot of increased uptake around the muscles. And then D is a truncation artifact. This is a very surface level coronal image, but you see the truncation there in the arm that's creating an artifact of misplaced counts. And the top picture here is showing muscles of mastication. The patient was chewing gum during their uptake period, and it resulted in increased uptake in the muscles around their gums. And then the second picture here is ocular activity. The patient was reading. You'll also see this when they're sleeping and they go into REM because the eyes have that rapid eye movement during REM sleep. And so you'll see that there's a little bit more intense uptake around the eyes. Now, these are all just normal variations of muscle activity. In A, you'll see it in the lower legs. B, you'll see it more in the neck and smooth muscle, but it is symmetrical in both. And then C is more nodular. C almost mimics the way that brown fat looks, but this was muscle uptake. Speaking of brown fat is also called BAT or brown adipose tissue. And this can create an artifact on FDG oncology images. It's a type of body fat that keeps you warm when you're cold. It stores energy, it helps your body burn calories, and it starts working or activates in cold temperatures. It's responsible for thermogenesis, so it's trying to be more active and keep you warm. It has several significant differences compared to white cells. For one, brown fat has more mitochondria in it. Remember, your mitochondria is the powerhouse of the cell, and it's responsible for respiration and energy production. So the mitochondria are also rich in iron, which is what gives the brown fat its color. And they also express high levels of UCP1, which is a protein used by the mitochondria to burn calories and generate heat. Brown fat also has more capillaries because it needs more blood flow and consumes more oxygen. And it's unmyelinated nerves, which stimulate the cells, preparing them to handle stress. Brown fat is linked to improving insulin sensitivity and blood sugar metabolism. So some researchers believe that our bodies recruit and activate brown fat as we enter into pre-diabetes as the first line of defense. Now, that being said, if you have a patient that's pre-diabetic, they may have increased brown fat uptake. Even though they're not diabetic yet, they may not even know that they're pre-diabetic. They may just have increased brown fat uptake as a normal variant. Brown fat is a problem for us in FDG oncologic imaging because it can either obscure or mimic metastases. Some factors that naturally increase the brown fat are being of the female sex, being younger age, having a lower BMI, and colder outdoor temperatures. Females with breast cancer, or patients who are not on chemo, and patients injected mid-morning versus early afternoon or early morning or mid-afternoon. And then one way to avoid that is by keeping the patient warm, giving them a warm blanket before and after injecting them, and that will help reduce the appearance of it. Now we're going to switch gears a little bit and look at specific types of cancer. The first one we're going to start with is one that you will see pretty frequently. This is solitary pulmonary nodule. Um, Solitary pulmonary nodules are seen on radiographs and CT. Sometimes they're even seen as, sometimes it's an incidental finding and sometimes they're seen in screening. There are CT screening that will look for pulmonary nodules. And the problem is they can be benign or malignant. And we don't want to biopsy all of them because it is a difficult biopsy for the patient. It's a high risk biopsy. And so doctors will only biopsy those with FDG uptake. The benign ones are not going to hypermetabolize glucose, but the malignant ones will. And so if it's showing up with increased activity on the FDG study, then it's time to biopsy it and see what it is. So a pulmonary nodule increased uptake is also seen with tuberculosis, fungal infections, or pneumonia. So it's important to take a good family history, and sometimes they will follow it up. They'll test the patient for other things, or they'll follow it up to see if it's resolving. And if it's not, then they'll order the PET scan. Um, Decreased uptake is almost always benign, but increased uptake is where you need that biopsy to see exactly what it is. And even if it is cancer, they need to still biopsy it to see what kind. So there's a couple images here. Image A is in abscess. And you have the CT plus the fused image there beside it. And then for B, it's 6 months later, same patient, CT, and then the fused image, and you can see that the abscess has resolved and it is not malignant. Now, non-small cell lung cancer is one of the ones that you will see also. And PET is better than CT or MRI for non-small cell lung carcinoma. Um, and it's really good at finding lymph involvement in distant metastases. So PET CT scan is always useful and it's always ordered because it's very useful to stage the patient, but then also to help determine their therapy plan. So the image here is a PET CT study in a patient with esophageal and bladder cancer with a new 2.9 centimeters spiculated mass seen on the CT scan. Image A is in the left lung. You see that it is FDG avid, and you see that in A is just the CT, B is actually the PET study. We don't have any fused images for this one. The solitary pulmonary nodule has an SUV value of 16.5 and is found to be a third primary cancer of non-small cell carcinoma. These are coronal images of a CT for A and then the FDG scan for B, no fused images. This is also a patient with lung cancer, but this is small cell lung carcinoma, which shows disease presented by a large accumulation of FDG in the right hilum and mediastinum, seen right here where my mouse is. Note that there is normal activity in the liver, spleen, kidneys, ureter, and bladder. That's important to look for metastases. Non-small cell or small cell lung cancers make up 15 to 20% of all lung cancers, and they can be known as oat cell carcinomas, small cell undifferentiated carcinomas, or poorly differentiated neuroendocrine carcinomas. This is one that you don't see yet for dotatate, or it's kind of off label for that, but some of the it is neuroendocrine as well. Right now we still do FDG for those, and the incidence of small cell lung cancer is rapidly increasing in women. This is an example of mesothelioma. Image A is the CT, B is the FDG scan, and then C is the fused images. This is a patient who was experiencing fever and left chest pain with known exposure to asbestos who was diagnosed with mesothelioma. You can see on the fused scan that it demonstrates the exact location of the intense FDG uptake. That you kind of see it cloudy here on the CT because it is more dense. And then on image B, you see the FDG uptake kind of around the outside of it. And then in the fused image, you can see the exact anatomic location of where the activity is. Mesothelioma is rare, but it seems like as rare as it is, you'd still see it fairly often with PET. I guess it depends on what area of the country you're located in as well. But it is considered rare. It develops in the pleura of the lungs in people who are exposed to asbestos. And it has a really long latency period before it becomes malignant. This is an example of extensive metastases from malignant melanoma. Note that the normal intense brain activity may hide metastases because melanoma is known to metastasize to the brain. Melanoma is extremely aggressive, and this one looks like it just happened to be the image that I have cut off at the ankles, but you would go all the way through the toes with these patients. I have seen patients with melanoma on the toes or melanoma that metastasize to the skin on the toes and lower extremities. It can really go anywhere. And this is a pretty good picture of what melanoma looks like. It is very aggressive and it has a high risk for reoccurrence. And so I do want to caution that melanoma is not just something that happens in Caucasian people. It happens in every race. And unfortunately, people with darker skin usually don't go to the doctor because they either don't see it or they don't think that they can get melanoma. So these people do need a total body assessment, and typically they will get an aggressive treatment as well. Now, this is another example of melanoma, but this is in the early stages. This says faint scalp melanoma with metastases present on both coronal and sagittal views. In A, there is also right axillary and posterior mediastinal metastases. There's faint skin surface metastases that may sometimes be missed with attenuation correction protocols, or if there's a slight misregistration. But I'll point it out to you here in the scalp. You see right there on the sagittal and coronal, you can see it. You also see it right here in the axilla area on the right, and then mediastinal area right here where my mouse is circling. This is FDG evaluation of the response of lymphoma to chemotherapy. The pre-therapy scan in A shows intense activity in multiple mediastinals, supraclavicular, splenic, periportal, and left inguinal metastases. And then after 5 months of therapy, the lymphoma is in complete remission. So mediastinal is right here around the chest. Supraclavicular is up here by the clavicle, just above the clavicle. Splenic is over here by the spleen. Periportal and then left inguinal metastases is right here in the left groin area. So with lymphoma, remember there are two types, Hodgkin's and non-Hodgkin's. Non-Hodgkin's is more common. Hodgkin's is a little bit easier to treat, but both are bad. There are also several subtypes to each. Lymphomas are very FDG avid, and so you'll see a lot of FDG scans for patients with lymphoma. FDG is very good for staging and treatment response. Now, this is an example of multiple myeloma. Multiple myeloma is a disease that begins in the bone marrow when B lymphocytes form a mass. If a single mass or tumor is detected outside of the marrow, then it's known as plasmacytoma. However, it's usually more than one site, and it can turn into more than one site, and then it's called multiple myeloma. PET is a very integral part of staging and determining the extent of disease in these patients. So the image here is a patient with a history of plasmacytoma after radiation therapy, and it illustrates recurrent disease within the right ileum. CT scan is on the left. So this is an example of multiple myeloma. It looks very similar to melanoma, but it's a very different disease. Of course, this is more within the blood. So this is the PET images here, A, B, E, and H. C, F, and I'm not sure which letter this is. I is the CT, and then the images here, D, G, and J are the fused images. For melanoma and multiple myeloma, you see the importance of going the vertex all the way to the tip of the toes. This patient has cancer in their feet. You wouldn't see a lot. Look how much you would basically not be able to detect if you just did eyes to thighs with their arms up. So it's very important to do arms down, include as much as you can. And this patient has it in their hands even, which you would not see if you're doing eyes to thighs with arms above their head. So it is very important. It also has a very good value of doing PET CT with these patients because it helps you see exactly anatomically where those nodules that you see are. This is extensive colorectal metastases with disease occurring in the presacral, left iliac, hepatic, splenic, and right pulmonary locations. Here's the right pulmonary. Of course, you see it in the liver, the spleen. Down here, you see it in the right iliac. I think that's what I said. No, I said left iliac. Left iliac and right pulmonary locations. That's what I meant to say. You'll see colorectal cancer patients a lot for PET CT because it is the fourth most common cancer behind melanoma, lung, prostate, and breast. PET CT is very good at finding extrahepatic involvement, and it is expensive, but can determine which area is non-resectable and avoids more costly surgical procedures. This is an example of head and neck cancer. You see more than intense activity, more than usual in the salivary glands that's equal to brain activity. Squamous cells are thin, flat cells that look like fish scales and are found in the tissue that forms on the surface of the skin, the lining of hollow organs of the body, and the lining of respiratory and digestive tracts. 95% of head and neck cancers are squamous cell carcinomas, and they tend to be FDG avid. You'll also see other types of squamous cell carcinomas like skin cancer that will be FDG avid, even though it's not necessarily melanoma. This is an example of esophageal cancer. These are all fused images. Typically, we can diagnose esophageal cancer not until it gets to the advanced stages, which leads to a poor survival rate. In 2001, PET imaging was approved for esophageal cancer for CMS. And so even though it's not that common, pretty much everybody with esophageal cancer gets a PET CT study. Now, breast cancer, there are a couple different things that we can do for breast cancer. There is a fluorestradiol now, which will go to the hormone recepting breast cancer, but all breast cancer patients, even those ones, will still get FDG. Excluding skin cancer, breast cancer is the #1 malignancy for women. Most important prognostic factors are the number and extent of axillary and other lymph node involvements. And so PET is best at accurately assessing the extent of lymph node metastases. Now, patients with breast cancer, you will see a lot in nuclear medicine. They will get a regular bone scan, either sodium fluoride PET or regular MDP-HDP bone scan when they're first diagnosed and as part of their staging, because breast cancer does tend to metastasize to the skin. You'll also do lymphoscintigraphies on those patients because it's important to locate the sentinel node and biopsy the sentinel node during that initial resection of the tumor. And then that helps to determine their prognosis. They will also get the FDG PET scan as a baseline as part of their initial staging, and then periodically through their treatment. They may also get the F18 fluorestradiol studies if they find that they're hormone receptor positive. And then you may also see these patients get MUGA scans, or the, looking at the ejection fraction of their heart, because the chemo that they take is very toxic to the myocardium. So you'll see breast cancer patients a lot in nuclear medicine, but the FDG studies are pretty commonly seen that they get repeat FDG studies when they're initially diagnosed, periodically through their treatment, and then later as follow-ups. And what they're looking for with the FDG studies, of course, you can see metastases anywhere, but they're primarily looking for the lymph nodes. And then it's really good for patients with previous lumpectomies because there's a lot of scar tissue in the area that make it harder to see on other imaging. And scars can mimic recurrence on other imaging. And breast cancer, or the FDG, is really good for looking at response to therapy. This is an example of serial FDG scans used to monitor breast cancer therapy. A shows increased activity in several left axillary lymph nodes. After 3 months of chemo, the nodes are still slightly visible, but you can see it's responding to treatment. And then image C is after 5 months, there's only faint activity that remains in the lymph nodes. So this is one of the reasons that we do SUV calculations. The SUV value would be fairly high in this baseline study, less in B, and then probably within normal limits on C. And so that's one way that they're looking at response to therapy, not just visually, but quantitatively. Now, this is a patient with prostate cancer. Besides skin cancer, prostate is the most common form of cancer for men. And then, of course, remember we talked about colon cancer being in there too. And lung cancer is more deadly, but less common. So we see lung cancer patients also. FDG does not do very well with prostate cancer, but it is fairly common that patients will still get an FDG study. There are new targeted PET tracers for prostate that we talk about later. There's a couple different ones. There's fluciclovine, which is an amino acid, and then there's quite a few PSMA agents. So the activity is present on transaxial, sagittal, and coronal images just below the bladder. That represents prostate cancer. You can see it right there. It's teeny tiny. You barely see it in A. Right there, it's very tiny. However, normal activity in the bulbous urethra may appear in a similar manner. So it's not uncommon to see residual urine there, or the bladder may be so hot that it masks it. This is one of the reasons where one of the times where the doctor may order a catheter just to clear that activity out of there so they could see the soft tissue better. If the patient has an indwelling urinary catheter because of their prostate cancer, that can cause a false positive on FDG because the area around the urethra will be inflamed or could be infected, which would take up FDG. And so these are some of the reasons that FDG really does not do very well for prostate cancer patients. It gets very complicated and very hard to see that tissue around the bladder. This is a cervical cancer patient. FDG scans are used for initial staging, and then limited data exists on using PET to manage recurrent cervical cancer, but it is used for initial staging. The images here, CT is A, PET is B, and then C is the fused image. This is a patient with squamous cell carcinoma of the cervix that shows FDG activity consistent with primary tumor. B is the sagittal PET that shows the region of tumor uptake just above the bladder. You can see it right here in the cervix. And then the fused images shows the correlation. This is very similar to prostate in that the anatomy is so close to the bladder that it makes it hard to detect it on FDG images. And this would also be another case where it may be useful for the patient to have a bladder catheter in place, urinary catheter, to clear that activity out of the bladder. This is an example of ovarian cancer. This is a patient with ovarian cancer that demonstrates extensive hepatic, peritoneal, and pelvis metastases. So this is the peritoneum, peritoneal, right? The inside of their abdomen lining. This is the hepatic, and then this is the pelvis ones. And then B is a different patient. B is a patient that had recurrent ovarian cancer in the soft tissue in the pyloric region. So you see kind of near where the stomach would be. You see that hot spot there. Ovarian cancer is fairly common. Unfortunately, it's also very deadly. It originates in the epithelium and it's FDG avid. PET is used as a screening tool. Not necessarily regular screening tool, but only when it's suspicion. And then it's also helpful in response to therapy and patient management. This is an example of testicular cancer. There are two categories here, non-seminoma germ cells and seminomas. Both are FDG avid. The exception is mature teratomas. Those are not FDG avid. They're more amino acid, I believe. But future PET tracers may improve the detection and differentiation of many of these types of cancers. And this patient in this image is testicular cancer, and it shows a large collection above the bladder, right here in the pelvis where my mouse is. And that represents retroperitoneal metastases. It is commonly occurring, normally increased activity in the stomach that I want to point out on this, and in the colon. Those are both normal, especially in the descending portion of the colon. And this is one reason why some places will give bowel prep if it's questionable. Now, this is an example of thyroid. Of course, we think of thyroid cancer more often being seen with I-123 and I-131. but it can also be used with PET, and there are several different types of thyroid cancer. A represents normal patchy activity in the thyroid. B has asymmetric intense activity that's associated with a multinodular goiter with chronic autoimmune thyroiditis. So this is chronic inflammation in B. And then C is very symmetric uptake that's associated with lymphoma of the thyroid. So that's something that you may see when it's symmetric like that. It's typically associated with lymphoma. If you see it very faintly, that's probably normal. And then if you see this asymmetrical uptake like this, it's hard to tell what it is actually, but if the patient has a history of thyroiditis, Hashimoto's, any kind of autoimmune in that area, then that could indicate that there's chronic inflammation, not necessarily cancer. Thyroid cancers with FDG can be a little tricky because there are a couple different types. Recurrent thyroid cancer with a negative I-131 whole body scan may be a good indication for FDG. That's a reasonable diagnostic approach in patients where thyroid cancer or thyroid metastases is indicated or a concern, but they have a negative I-131 whole body scan. Unexplained abnormal findings in the thyroid bed on FDG PET scans obtained for other indications require additional conventional tests such as ultrasound, I-123 scintigraphy, maybe biopsies, and this can be performed to exclude unsuspected thyroid cancers. Now, FDG accumulates in residual nest of thyroid cancer, and this is seen here in this patient on the right side of their neck. These lesions were not demonstrated on whole body I-131 scans, and this could be because the cells are highly malignant and they are no longer taking up iodine. Now they're taking up sugar to metastasize. Pancreatic cancer is one that has a really bad prognosis. The 5-year survival rate is only 7%. So 93% of the people that get diagnosed with pancreatic cancer will die within 5 years. The incidence rates have declined in the last couple of decades, and the disease remains a silent killer because of the difficulty in finding it and diagnosing it in the early stages. PET can be helpful for differentiating chronic pancreatic mass from malignancies, assessing for metastatic spread to the liver, and predicting response to chemotherapy. One problem is a high incidence of poorly controlled diabetes with pancreatic carcinoma, and elevated serum glucose levels cause decreased FDG uptake. So if you think about what your pancreas does and how it helps to maintain your blood sugar, of course, when you have cancer there, that can lead to problems with digestion because your pancreas releases digestive enzymes. And then it can also lead to problems maintaining your blood sugar, which complicates the ability to do FDG scans. So this is an example of pancreatic carcinoma. A to C is CT, PET, and then fused images on a patient with pancreatic carcinoma after chemotherapy. The patient has recurrent disease in the tail of the pancreas and a new lesion in the inferior pancreatic tail. In addition, there are 2 nodes found in FDG in the mediastinum, which means it's probably metastasized. This is an example of FDG in a patient with gastric cancer. Gastric cancer is considered fairly rare, but you will see it probably pretty regularly if you do a lot of PET studies. The majority of gastric cancers are adenocarcinomas. One of the problems with this is it's often aggressive and hard to diagnose before it's in advanced stages. Similar to pancreatic cancer, if you think about with pancreatic cancer and gastric cancers, remember cancer spreads three ways: through the blood, through the lymph, or by seeding to nearby organs. And with the location of the pancreas and the stomach, there are a lot of vital organs close by. You have the mesentery and peritoneal cavity, and you have good blood flow in that area, and you have a lot of lymph nodes. And so it can spread any of those ways and become very aggressive. But FDG in recent years has become useful to complement clinical care in gastric carcinomas, and the evaluation of treatment response is a crucial part of the continued management. And then the images here for A and B are a patient with a metastatic gastrointestinal stromal tumor of the stomach for assessment of treatment response. And the scan shows interval progression of the disease with new increasing FDG activity in the skeleton, soft tissue, and liver. You see a lot of it here in the abdominal cavity, in the liver, in the mediastinum. You see some activity up here in the neck. And so this is probably a fairly poor prognosis for this patient. I do want to note that adenocarcinoma starts in glandular tissue that is usually lining the organs. This is hepatocellular carcinoma, abbreviated as HCC. This is an avid hepatocellular carcinoma in both lobes of the liver. In this patient here on the left, there is evidence of extensive FDG avid tumor thrombus in the branches of the portal vein and in the main portal vein. It's hard to see here because it's so dark. Hepatocellular carcinoma is a term used to denote only primary liver cancer, and many cancers spread or metastasize to the liver. Benign tumors of the liver could be adenomas or hemangiomas. PET scan can help differentiate that, but typically patients will get the nuclear medicine hemangioma. This is endometrial cancer. The patient here on the left is a patient with endometrial carcinoma. The FDG study is seen on the left, and then B is the CT. It shows active tumor progression involving the uterus and then progressing through the abdominal cavity, in the liver, up here in the supraclavicular area, some in the chest. It's hard to see without having other views or slices if that is lymph node or in the lungs or where that has metastasized to. But FDG lymphadenopathy within the neck, abdomen, pelvis is present, and there's also liver, lung, and bone mets. Endometrial cancer is the most common female gynecologic cancer in the U.S. Expansion in access to PET continues to improve the routine diagnostic tools. Typically, patients get transvaginal ultrasound, CT, and MRI for preoperative staging, but PET-CT has been found to assist in management to discern involvement of metastases and also in treatment response. Now, sarcomas, there are a lot of different types of sarcomas. Sarcomas are bone cancers, and they are also seen on sodium fluoride bone scans. Malignancies that develop in the connective tissue, such as bone, muscle, fat vessels, and linings of the joints, are all known as sarcomas. CT and MRI are often used for diagnosis, staging, and grading, but PET is also useful. With the unique characteristic and broad range of sarcomas, PET provides value to clinicians in clinical management, detection of metastases, and response to treatment. There are several different types of sarcomas, like I said, but a few of the most commonly known ones are osteosarcoma, Ewing sarcoma, which is essentially osteosarcoma in children, rhabdomyosarcoma, chondrosarcomas, angiosarcomas, and liposarcomas. If you remember back to your medical terminology, this first part of the word kind of denotes what kind of tissue it is. Chondrosarcoma tends to happen in the cartilage area. Liposarcomas tend to be more fat. So you can help remember where it's originating from that way. This is an example of osteosarcoma. An osteosarcoma or osteogenic sarcoma is cancerous tumor in the bone. Specifically, it's very aggressive malignant neoplasm that arises from primitive transformed cells of the mesenchymal origin that exhibits osteoblastic differentiation. So in the image here, this is a patient that had a PET CT study for subsequent treatment strategy showing a mixed response with therapy. There is multifocal skeletal involvement of the osteosarcoma. This is an example of Ewing's. Ewing's sarcoma is a type of cancer that forms in the bone. Symptoms may include swelling and pain at the site, fever and bone fractures. The most common areas where it begins are the long bones of the legs, like the femur, the pelvis, or the chest wall. And this study here shows FDG avid tissue in the right mandible, right there in the jawbone, and a soft tissue component with masticator space in the patient that has Ewing sarcoma, and activity is consistent with disease progression. And then the CT scan is shown on the right side. This is rhabdomyosarcomas. These are highly aggressive form of cancers that develop in the mesenchymal cells that have failed to fairly differentiate into myocytes of skeletal muscle. Cells of the tumor are identified as rhabdomyoblasts. So this is an FDG in CT study of a somewhat superficial rhabdomyosarcoma of the right thigh. You see it right there. There's just a little faint little dot. And this patient was being evaluated for surgical procedure to remove it. This is an example of a chondrosarcoma. This is considered a type of bone sarcoma, but it's a primary cancer composed of cells derived from transformed cells that produce cartilage. And a lot of times what happens with chondrosarcomas is someone will have a congenital defect where cartilage grew instead of bone. So they may have a section of their femur where there's bone around it, but there's a section of their femur where cartilage grew instead of bone. And they won't feel it. There won't be any symptoms, maybe transient pain in the area, and it will go undiagnosed for their lifetime and they'll be fine. Or at some point, it could turn into a chondrosarcoma, and at that point, it becomes a little more aggressive form of a bone cancer. Chondrosarcoma is a member of the category of tumors of bone and soft tissue known as sarcomas, and about 30% of bone sarcomas are chondrosarcomas. Unfortunately, it is resistant to chemo and radiation. A lot of times the only treatment is to amputate, but if it's towards the head of the femur and it's aggressive and metastasizes quickly, then it becomes very hard to do that. So the patient here on the left received a PET CT study, and it shows progression of recurrent and metastatic chondrosarcoma that is taken up by the FDG. It shows recurrence in the right pelvis as well as the soft tissue. You do see that it has metastasized to the lungs. And then there's also some bone activity, which you can see right here in the spine. This is an angiosarcoma. Angiosarcomas are very rare, so it's probably not going to be very often that you would see a patient with an angiosarcoma. but it is a very aggressive cancer that starts in the endothelial cells that line the walls of the blood vessels or lymphatic vessels. Remember, I told you to look at the first part of the word to tell you where the sarcoma is originating from. Angio typically refers to blood vessels. So this one originates from blood vessels or lymphatic vessels. And then the patient here on the left is a patient with an angiosarcoma that got a PET CT study. It's arising in the pericardium and involving the right atrium of the heart. So you actually can see it, small picture, and I'm sorry about that, but you can kind of see it right here in the CT and the PET study. Now, liposarcomas, they are a very common subtype of soft tissue sarcomas, which are the ones that originate from soft tissue, and they account for at least 20% of all sarcomas in adults. They are still considered fairly rare, though, but there are over 150 different histologic subtypes or forms. There's a lot of different types of soft tissue and things like that in our bodies. And the liposarcomas arise from precursor lipoblasts, or the adipocytes and adipose tissue. So remember, adipose tissue is fat. So these are basically originating from fat cells. That doesn't necessarily mean that the person is obese. It just happens to be where the cancer derives from. So this image here is a patient with a liposarcoma who had a PET CT, and you see a large hypermetabolic mass in the anterior mediastinum right here in the chest. There's extensive hypermetabolic adenopathy extending along the subcarinal. Carina is right here in your chest, so it's just below that. So you're seeing it like down here. Where my mouse was, and paraesophageal activity. So it starts down here, just below the carina, and you see it all around the esophagus. Notice this patient is not obese or overweight. You don't think of having a lot of fat cells necessarily around your esophagus or in your chest, but that's part of the problem with liposarcomas. You have fat cells everywhere in your body that could develop into it. This is an example of leukemia. This is a cancer that's arising in the blood, and it's further classified by the type of cells involved, like myeloid or lymphocytic. There are several different types and subtypes of leukemia. And PET imaging is now approved through CMS for liquid tumors or tumors of the blood and fluids of your body, which it for the longest time it wasn't. So you didn't typically used to see a lot of leukemia or even multiple myeloma patients for FDG scans, but now you're seeing more of that because CMS does approve it. And in the patient here, you'll see extramedullary disease in multiple sites in the head, neck, abdomen, and musculoskeletal system. And the finding in the sacrum is consistent with biopsy results of acute myeloid leukemia and with recent cerebrospinal fluid findings of blast cells. You can see some activity here in the brain, and then you see the activity around the jaw and the neck. And then in the coronal view, you kind of see it all through the abdomen. And then this is something that you'll also see with FDG PET imaging, where a patient has an unknown primary tumor or unknown primary carcinoma. So if you see a diagnosis of CUP, it means carcinoma of unknown primary. And gene profiling can be used to better diagnose and direct the treatment, but a lot of times FDG study is ordered to help locate the site of a primary tumor or determine whether or not it's FDG avid. But this is a cancer of unknown primary with multiple hypermetabolic metastatic sites, and FDG. I've actually seen a patient like this before, and it turns out that they had this very, very rare cancer that only occurred in veterans who had worked with a certain chemical during combat. And it had some weird, really long name to it that I'd never heard of. It wasn't really in books. So if patient presents with a cancer like that, sometimes it's very hard for the doctor to figure out the diagnosis. And FDG scans can help rule out or confirm other things, or even help narrow down the search by seeing if it's FDG avid or not, and avid or not, and helping to understand the metabolism within the tumors. Now, there are several situations that can lead to benign uptake, meaning normal cells that are uptaking FDG, and there's several things that can interfere with FDG uptake. So the ability for doctors to really read and interpret FDG studies can be very tricky. And that's one of the reasons that it's extremely important for the technologist to take a thorough history and ask the patient questions if you see something abnormal. That can be tricky because you don't want to tell the patient, hey, I saw something abnormal in your thyroid. Have you ever had thyroid problems? But it's something that you may want to ask them if they've had recent surgery or any thyroid problems, just as you're walking them out. Very delicate line there to be able to get the information you need and not freak them out in some way. But there are lots of physiologic uptake that will take up into normal cells, salivary glands and lymphoid tissue in the head and neck, thyroid tissue, orbital, speech, and tongue muscle, especially in children, brown adipose tissue, that brown fat we talked about, the thymus, especially in children, lactating breast, or in the areola. Skeletal and smooth muscle, especially if they've had recent exercise or hyperinsulinemia, which is high levels of insulin. Laryngeal muscle uptake with phonation, masticator muscles from uptake with chewing. Don't let your patients chew or eat gum during chew gum during the uptake. Diaphragm or intercostal muscle uptake. This can be seen in pediatric patients, especially if they're crying, or in patients that have labored breathing. This could just be normal labored breathing for other reasons, or you may see it more in patients with types of lung cancer. Gastrointestinal tract, stomach, bowel, anal sphincter, large bowel uptake, especially in patients with who are taking metformin. And then urinary tract structures, because FDG will excrete it, so it's normal to see high uptake in the kidneys, ureters, or bladder. Female patients in the genital tract, especially the uterus during menses, or if they have any kind of cysts that may show up. Skeletal, especially the ends of long bones in children who are still growing. The axillary node uptake, and you'll see this from infiltration of the dose at the site of injection. You can see it in patients who recently got tattoos. And then you also see it secondary to people who have received a COVID-19 vaccine. They will have uptake in the lymph nodes of the armpit, in whatever arm they got that vaccination in. There are some infectious and inflammatory diseases. Anything that causes inflammation or infection is going to uptake some FDG. So post-procedural inflammation, infection, bruising, and this can be seen biopsy sites, sites of thoracentesis, paracentesis, amputation sites, any kind of ostomy site or port that's put in. Post-radiation inflammation, you'll see this. An example I have here is radiation pneumonitis. You also see it in the brain if they have any kind of radiation therapy to the brain. Just anywhere they're getting that can cause localized inflammation. Post-chemotherapy changes. Sometimes this could be inflammation. Sometimes it's tissue necrosis. Local inflammatory diseases. Fungal infections, sarcoidosis. I showed you a case study where a patient had an ear infection. That will show up. Of course, the injection site might show up. Thyroiditis we talked about. And I showed you a picture of what that would look like. Esophagitis, gastritis, inflammatory bowel disease, appendicitis, or autoimmune diseases of the gastrointestinal tract. Those will all cause chronic inflammation in whatever area that they're affecting. And so that would be FDG avid. Acute and occasional chronic pancreatitis, acute cholangitis or cholecystitis, so that's in the biliary tree and the gallbladder, osteomyelitis, recent fractures or joint prosthesis. It's going to show up, that will also show up on a bone scan. Lymphadenitis and reactive lymph nodes, especially in children, or any kind of vascular inflammation like vascularitis or atherosclerotic disease. Any kind of coronary artery disease may be FDG avid. Benign tumors or tumor-like conditions, pituitary adenomas, adrenal adenomas, thyroid gland follicular adenomas, salivary gland tumors, colonic polyps, so polyps in the bowel, ovarian sarcomas or cystadenomas, skeletal, you could have bone cysts, endochondromas, giant cell tumors, and then neurofibromas and leiomyomas. Most of those different types of benign tumors are pretty rare, but it would show up. Hyperplastic and dysplastic conditions would be like Graves' disease, and Cushing's disease. Those are both endocrine mediated that will lead to inflammation. Bone marrow hyperplasia, and you see this with colonnade stimulating factor or patients with anemia. Thymic rebound hyperplasia, this is in the thymus after chemo. And Paget's disease is on there too. Paget's disease, if you remember, is not cancer, but it is hyperplastic. The bone cells will overgrow and the bones get really thick. There are several different types of artifacts. Most of them we talked about in earlier lectures, but the misregistration or misalignment between PET and CT, inaccuracies in converting the polychromatic CT energies to 511 keV, and this can cause artifacts around any kind of implanted devices, metals, contrast, anything like that that's going to be hyperdense. Motion artifacts, edge artifacts and truncation artifacts, you'll see misplaced counts around the edges. And then metallic artifacts will be very similar to when you have something that's super dense. And lastly, situations that can lead to false negatives. If the lesion is too small, if it's less than twice the resolution of the system, it may not be able to be seen. Patients with hyperglycemia or hyperinsulinemia, that FDG may not uptake because the cells are already oversaturated. Recent therapies like chemo, radiation, or steroids, tumors with low metabolic activity. These are certain low-grade or well-differentiated tumors, such as mucinous neoplasms that include the lung adenocarcinoma in situ, prostate carcinoma, carcinoid tumor and inlet cells, carcinoid tumor and inlet cells, as well as medullary thyroid cancer are more neuroendocrine. Prostate cancer can be masked because it may not be FDG avid, but it also might be masked by the bladder. Lobular carcinoma on the breast, it's not really FDG avid. Hepatocellular tumors, including well-differentiated hepatocellular carcinoma, it may not be FDG avid anymore. And then indolent lymphoma, including marginal zone lymphoma or small cell lymphocytic lymphomas. So in the future, PET-CT scans are going to be increasingly more valuable to patients with oncological conditions. New instrumentation is coming out and being improved every year. We now have digital PET CT and total body digital PET CTs, and that increases the sensitivity and the resolution, so patients can get lower dose and their scan times can be faster. The reconstruction and processing is becoming more sophisticated with advancements in computer programming and software engineering. And one of the examples is iterative reconstruction. We went from filtered back projection to now we use iterative reconstruction, and the iterative reconstruction algorithms are changing. We've gone from OSEM to now there's MLEM and lots of other different types of iterative reconstruction that's very advanced. PET CT can be used for targeted gene therapy and looking at the overall efficacy of new therapies. We have a lot of advanced radiochemistry that is not only really improving FDG, but adding other radionuclides that can be used in conjunction or in place of FDG for certain types of cancer. And FDG PET scans are becoming more accessible and more affordable. We see more and more CMS approvals and private insurer approvals to allow patients to get PET scans earlier and more frequently, and better reimbursement for them. And there are a lot of new radiopharmaceuticals being developed. For the longest time, FDG was all we had for PET oncological imaging, and now, as you see, from earlier lectures and what we'll talk about later in this class, is that there are a lot of them now, and they're increasing with number, and it makes it a lot easier and more specific. It gives cancer patients a lot more options, and oncologists a lot more options to get better answers, better data to make better decisions for their patients. So that concludes this lecture. Please let me know if you have any questions. Thank you for watching.